Hello and welcome. My name is Alisa Stoddard and I'm the Executive Director for the Utah chapter of the American Academy of Pediatrics. We would like to welcome you to our 2018 HPV QI project. This is an exciting project that will have participating practices from Alaska, Utah, and Wyoming. The project is being funded by a grant from CDC and the National AAP. The project will be run and organized through the Utah chapter, and at the successful conclusion of this project, all participating physicians will earn 25 points of MOC Part 4. Physicians must complete 5 consecutive months of data collection to qualify. The project must be completed by September 28, 2018. However, data collection will need to end at the end of August. With this kickoff conference today, we will be introducing you to quality improvement tools and techniques in the hope that you will continue to use QI processes in your practices in the future beyond this project. You will be introduced to AAP's QIDA, the Quality Improvement Data Aggregator, as a tool to help you gather your data and display your own results. We will be also reviewing human papillomavirus incidence and prevention. As this project involves using QI to effect further improvement in your HPV vaccine delivery. Each team is expected to include pediatricians and office staff, from mid-levels to nurses to medical assistants, even including your front office staff. In short, everyone should be participating in the project. Each office should identify a project leader to help me with the logistics. If you haven't already, please get me a name, email, and phone number. Our partners with this project are the Intermountain West HPV Vaccination Coalition and UPIC, Utah Pediatric Partnership to Improve Healthcare Quality. The HPV Coalition will provide ongoing and up-to-date information about HPV vaccination and HPV cancer survivors to bring enthusiasm and relevance to your team's efforts. UPIC's role will be to help you implement evidence-based best practices. By making important incremental changes, you will be able to see what is working and what is not, and how to make relevant and sustainable changes to your procedures. We will be holding monthly 1-hour teleconferences. These conferences will include short didactic sessions to cover common problems and opportunities for individual practices to share their successes and failures. We intend to celebrate both successes and failures. These conferences will be held on the first Tuesday of every month from 8 a.m. to 9 a.m. Mountain Standard Time, so in Alaska that will be 6 to 7 a.m. We chose the time to be after your hospital rounds or before for Alaskans and before you start seeing patients. We will be recording this conference for those who cannot attend live. Uber Conference, the service we are using, is HIPAA compliant, so individual patients may be discussed. We will have experts available to you throughout the project to help you succeed in this effort. Today I will introduce to you experts in HPV and QI. These experts will be available to you over the next 6 months to help you solve any problems that may come up. Our first goal is to have each of you gain success, and our second is to make this as easy as possible. Thank you for joining us. Our first speaker will be Dr. Deanna Kepka with the Intermountain West HPV Vaccination Coalition.
So I don't have any financial disclosures to reveal to you. I haven't taken any pharmaceutical funding for any of my research, and I'm pleased to say that. Here are the topics I'm going to cover in my presentation. As I mentioned before, I'm going to talk about cancers and precancers related to human papillomavirus infection. I'm going to talk about what's going on with vaccination rates in the Intermountain West. I'm going to talk about how we need to reframe this vaccine as a cancer prevention vaccine, and then speak about the work of our coalition and help you with access to resources that we could provide to help improve HPV vaccination in your clinical environment. So we could be preventing almost 30,000 HPV-related cancers each year if we got our HPV vaccine rates up to where they should be. Let me say that again, almost 30,000 cancers each year. That's almost as big as a football stadium here, or a pep concert arena. Yet we're battling negative media and a lot of stigma around HPV infection and this vaccine. Here in Utah, and I'm sure in Wyoming, you have similar issues. I need to get more up to date on Alaska, so please share with me any resources so I can learn more about what's going on up there. We've had headlines such as this one: Utah youth are having problems getting access to this vaccine. We have some of the lowest vaccination rates in the country. And then we have parents fearing that this vaccine might cause children to think that it's okay to have sex. And so they're not thinking about this as a cancer vaccine, but they're thinking about this as a vaccine that induces promiscuity. And I'm here to tell you that that's just not true, and that's not helpful, and that's not going to help us prevent those 30,000 cancers each year in the U.S. And we need to remove that stigma around a human papillomavirus infection. And let me tell you why. Because who gets HPV? We all get HPV. 80% of us will have HPV infection at one point in our lives. We just won't know it. Most of us will clear it within 6 months to 2 years and have no symptoms. That's the tricky thing with this virus. That's why people don't talk about it like they do chlamydia, gonorrhea, or HIV. It's just this hidden secret virus with no symptoms that you don't even know you have it when you're infected. 1 in 4 sexually active people are infected right now, and the highest levels of infection occur when people are in their teens and 20s. And that happens because these rates spike soon after sexual debut. That's when the body is least likely to have immunity to the HPV types that they would be exposed to during sexual activity. HPV does not just cause cervical cancer. It causes 7 different types of cancers. It does not just cause women's cancers, it causes cancers in men too. Cervical cancer is no longer the #1 HPV cancer in the US. Male HPV oropharyngeal cancer is now the #1 HPV cancer in the US. Let me repeat that. Male HPV oropharyngeal cancer is the #1 HPV cancer in the US. So it's the changing demographic of HPV cancers. Cervical cancer has highest incidence among vulnerable patient populations. There's a lot of disparities because it's related to women having less access to Pap testing, where HPV oropharyngeal cancer is most likely to occur in white men. So we need to not feminize this vaccine and recommend it strongly for both boys and girls. So what's going on with HPV precancer? So I mentioned that we have almost 30,000 cancers each year in the US that are caused to HPV infection. But how about the burden of precancers? So most women have Pap tests in the US, and that's good. When you look at the developing world, most people have not had Pap tests, and that's why you have such a high rate of cervical cancer in low-income countries. However, what people don't talk about is 1 in 5 women have had an abnormal Pap test. And most women don't realize that this abnormal Pap test is related to infection with the human papillomavirus. So an abnormal Pap test is detecting cervical dysplasia. And so 1 in 5 women have persistent HPV infection, which is causing that dysplasia. And it's impacting women at ages 25 to 54. And most of you know, especially the younger ages, 25 to 35, that's when women are thinking about having a family. And so the impact of abnormal Pap tests or precancers or cervical dysplasia often is different type of treatments like colposcopy, LEEP procedures that can impact a woman's fertility. In more extreme cases, it can cause hysterectomy. In fact, I was just a little bit blown away this week. I went out to lunch with one of my girlfriends who I hadn't seen since she had her baby, and she's a young woman, probably in her mid-30s, and she told me she didn't want to share with anyone, but that she had an abnormal Pap test when she was pregnant, but they waited until after she delivered her baby. And then she delivered her baby, and they did the procedure for removing a colposcopy for removing the dysplasia, and she started hemorrhaging, and she had to have a blood transfusion. And there was a good chance that she was going to have a hysterectomy, and she wanted to have a larger family. And it was just absolutely devastating. And this is a woman right here in Utah, and this is one of my good friends. And this is a woman who's been working in HPV vaccination work with me for quite a while. So this is real. This really affects people, and it affects a lot of people. And the HPV vaccine can affect that. It could affect this this trauma that women go through around having abnormal pap tests and the treatments that are related to abnormal pap tests at this time in their life when they want to have a family, when they want to be able to get pregnant. As any of you can imagine, there's huge lifelong issues that would be related to hysterectomy. Not only that, even if you don't have a hysterectomy, there's a lot of issues related to the treatments for cervical cancer or precancer dysplasia around body image issues, sexual discomfort, loss of libido. Sometimes there's issues around unemployment related to time missed from work for treatment procedures. So I think Dr. Cosgrove asked me to really bring this to your attention, that it's not just preventing those 12,000 cervical cancer, 11 to 12,000 cases of cervical cancer we have each year in the U.S. It's preventing all of those precancers, the 1 in 5 women, and all of those the related effects on women's lives related to those abnormal pap tests. So let's think about this HPV vaccine as cancer prevention. And you know what? This vaccine is so effective. We know you only need to deliver 2 doses now under age 15. It is so effective, only 2 doses are needed under age 15 that are spaced between the first dose is given, and then you need at least a 6-month interval before the second dose. So both doses should be given within 1 year. And that's why younger is better. Younger kids respond so much better to the vaccine that we can drop that 3rd dose. And the immune system is most responsive to the vaccine at that younger age. And you want protection before exposure. Now you could still provide HPV vaccines should be given at 11 and 12 or younger, 9 to 12. But if it's given older, it's a late vaccination. It's no longer at the guideline recommended ages, but it should still be given, and it should be given all the way up until age 26. And we can talk more about that later. These are the 9 types that are covered in the vaccine. So the vaccine has, over my time in this field, we have gone from there was first the bivalent vaccine, then the quadrivalent here in the US, and then the nanovalent. We have a phenomenal vaccine. Protects against 9 types of HPV. So that we have it protects against 9 types of HPV and 2 types of, so 7 types that are oncogenic that cause 90% of cervical cancers, and 2 types cause 90% of genital warts. So many of you may think, oh, what's so bad about genital warts? No one wants genital warts. And even this week we had a woman that we spoke to on the phone who had genital warts at the time of her pregnancy, and her daughter, at the time of the birth, her daughter became infected with HPV type 6 and 11 and developed what it's called JORP, which is juvenile onset recurrent respiratory papillomatosis, which means her daughter developed recurrent papillomatoses in her throat, which are like recurrent warts in her throat, which was caused to her mother's HPV 6 and 11. And so her daughter continues to have periodic surgeries because it's affected her ability to talk. So even 6 and 11 can have horrific lifelong effects. So those are what I was just explaining, the bonus that's covered in the most recent vaccine, and then oncogenic coverage is from 16 to 58, and then 6 and 11 are the genital warts coverage. So now I'm going to talk a little bit about our Intermountain West HPV Vaccination Coalition. So we have been around for about 3 years. We started with a grant from the National Cancer Institute, who gave the opportunities for cancer centers to do more in their catchment areas, do a better job of educating their patient populations about HPV vaccination. Cancer centers spend so much time treating patients and developing new ways to do a better job of treating different cancers. Why not also do a good job of disseminating what we already know works? So with this grant, we created the Intermountain West HPV Vaccination Coalition with the objective of trying to improve awareness around HPV vaccination and trying to help integrate that as standard care in our primary care settings in their Mountain West region. And as you can see, if you see Utah and Wyoming, we're in the bottom quartile in the country Alaska looks like they're doing pretty good, but I'm not sure like if there's sampling error because of the how rural of a state you are. I'll have to look at how you've done over time. But Utah and Wyoming have consistently been at the bottom of the country for numbers of kids who've received the HPV vaccine. We have less than half of our kids getting this vaccine, even 10 years out from when the vaccine has been recommended for girls. So this is our coalition. It covers the dark blue states are our most active states in the Mountain West region, and just shows like some of our stats around Utah's HPV vaccination rates. These are our goals. We're trying to work across disciplines. So we're working with immunization partners, cancer control, pediatric, primary care specialists, as well as parents and community members. We're trying to work across disciplines and across states and even across the country to build awareness and support for integrating this into standard primary care practice. So we really strongly recommend vaccination at 11 and 12 for boys and girls alike. We're working towards a coordinated plan. We have ongoing activities. We have grown tremendously since our kickoff, from only 2 states with 130 members at our beginning to now 375 members in 18 states. And we welcome you to join our listserv. We'd love to have you participate in our activities, and you could just participate when you can. Please invite any of your staff members, any of your medical assistants or nurses or administrative staff who'd like to learn more, because each month we try and keep our members up to date with the hottest topics in HPV vaccination right now. For example, just this month we talked about HPV oral pharyngeal cancers and having dentists work more in HPV cancer education. We talked about social media around HPV vaccine promotion. We have newsletters. We keep people up to date on the most recent news articles and journal articles. We are building our HPV Advocate program, which is our program that you're going to be most interacting with, is where we have persons who've been impacted by HPV cancers personally. Either they are survivors or they have lost family members from HPV cancers, who are going to share with their stories so you can see how real HPV is and how difficult it can be on persons' lives. See, here's the different speakers that we invite, and we'd love, as you get more involved with working on this in your practice, we'd love to invite you to come and speak on one of our calls and tell us about how things are going. We'd especially love to hear from someone from Alaska, get that perspective. Here's an example of some of our projects. We try and create culturally tailored materials. So one of our community groups that we've done some research with said they wanted brochures that included people that look like them. It was a Latino organization, and they didn't want to have those CDC materials that had like 10,000 words and no pictures, and it was just like so much text that you kind of got lost in the main point of it. So we created this really simple photo novella, and we're working now on tailoring this photo novella for other communities, such as American Indians and African refugees and African Americans. Here's another activity we just kicked off that I learned a lot about, was just hosting a live Twitter chat. And if you want to do something like this with one of your affiliated organizations, we'd be happy to help you. And last but not least, we're hosting a national meeting on June 7th and 8th, where we will be hosting all the nation's experts from CDC and the National Cancer Institute here in Salt Lake City. It's a 24-hour long meeting. It's free. There's no registration fee. There's just a fee for dinner if you wanted to stay for our very nice dinner at the Natural History Museum, where we will have a world-renowned speaker, Anna Giuliani, speaking about the elimination of cervical cancer in 10 to 20 years. So welcome any questions. This is my son. This is him on his 8th birthday. He actually turns 9 in a couple days, and I'm going to be leaving for his birthday party in a few minutes. And I'm really excited to march him on in and get that vaccine in a few weeks. So thank you so much. Myself and my team, Laura Martell, we're available to help you in any way through this quality improvement project.
Thank you, Dr. Kepka, for sharing your great advice and expertise with us. We are now going to hear from a survivor, Tabitha. She is going to be talking about her experiences and the trauma that she has experienced herself as she has dealt with the stigmas and the disease state itself. We're going to turn the time over to Tabitha.
Hello, thank you for giving me this opportunity to share my story with you today. I'm a mother, I'm a friend, I'm a sister, I'm a Christian woman, and I have HPV. And what I usually say about all that is life does not go as planned. I married at 20. I had 3 sons by the time I was 28. I was married for 18 years. And then suddenly I found myself divorced at 38. I then decided, and I found someone I loved, and I was remarried at 41. At 41, I had always done my best to be on top of my routine checkups with my gynecologist, and it was just one of those normal routine checkups. And I had been remarried, and my gynecologist was meeting with me, just the normal routine, and I was told right then and there that I had HPV. All of a sudden, I stopped right there in my tracks. I could not believe that that's what I was being told. I had what? I had how? Wait. The funny thing is, I have known about HPV from my work with Dr. Deanna Kepka as a community liaison. I had been helping bring awareness of the vaccine to many communities throughout Utah who face health disparities, and just to bring awareness in general of this vaccine. And here I was now in the doctor's office, in the room, being told that I had HPV. Really? I thought I had been a good Christian girl, and still think I'm a pretty decent Christian woman. I'm middle-aged by now. And as a Christian, I had chosen to wait to have intimacy till after I was married. But then I started connecting the dots in the doctor's office and thought, I've been remarried. I married a man who had been married before. I have HPV. I remember the nurse coming in and telling me, and I don't think anyone could have said anything at this moment that would have made me very happy, but she said, and I probably advise this not being said at this moment, you know, the man you just married gave you HPV. I sat on the table in the doctor's office, silent, and thought, well, what do I say after that? And these are the thoughts that came to mind. I'm a Christian woman and I have HPV, and life doesn't go as planned. At 42, surprise, surprise, I was pregnant with my 4th son. Wonderful, exciting new adventure. So I have HPV and I was pregnant. The doctors watched me very closely, took biopsies, did coloscopies, not colonoscopies. There is a difference. But it was very stressful. I remember sitting in the car in the grocery store parking lot, calling up Deanna, wanting her to bring some type of peace of mind to me and advice. And I was very grateful for her for doing that. And also gathering support from loved ones. And in the process, changing the mindset of my own extended family, where they had previous biases about this vaccination, and then realizing, oh, this vaccination is for more people than I had assumed, that it's for everyone, because life doesn't go as planned. So interesting enough, my 3rd son at the time, as I was pregnant, it was time for his well child check. He was about 11 or 12 years old at the time, and I remember taking him in, very pregnant, and going through that routine visit. At the end of the visit, where the pediatrician comes in and right before the doctor goes over the pages of vaccination descriptions that are offered. And the doctor got to the final vaccination page, which read human papillomavirus in big bold letters at the top. And then she proceeded to say these words that I'll never forget. You don't need to worry about this one. I stopped again in a doctor's office, wondering, first of all, did she really just say that? And why don't I need to worry about this vaccine? Why doesn't my son deserve this? Why not? Why not have this conversation? Is it because I'm a middle-aged Christian woman that doesn't fit whatever criteria is out there in the world? Or it's not really a vaccine that perhaps the physician or myself feel comfortable enough talking about? or it would make us feel uncomfortable, or when it's brought up, you're going to think, or I'm going to get angry and I'm going to think you're trying to promote sexual promiscuity for my young son. Is it because he is a boy and not a girl? I had so many questions going through my head at this time. Was it that we wanted to avoid a heated debate? Why didn't my son deserve the gift of cancer prevention? And that's what I love most about what I've learned working as an advocate with Dr. Cosgrove, is it's how we present it. This is a gift of cancer prevention. I believe that all of us, all of the children, all of the people in our world have the right and deserve the right to receive this gift. And it's time to talk. I'm a Christian woman, I'm a mother, I'm a friend, I have HPV, and life doesn't go as planned. Thank you.
Our next speaker will be Dr. Diane Liu with UPIC.
Welcome everyone. I'm so thrilled that I have the opportunity to meet with you. I thank Bill Cosgrove for inviting me to spend a little bit of time and talk to you about some information that I wished I had received when I had finished residency and went out into practice. And certainly as I've been involved in quality improvement work for the past 7+ years, returning to the university in this role has been a really great privilege. So it has given me an opportunity to work with some of you in Utah, and I certainly look forward to talking with those in Wyoming, Montana, and Nevada. So today I've entitled my presentation a focus on quality improvement and establishing those processes for change. I co-direct the Utah Pediatric Partnership to Improve Healthcare Quality. This is a state improvement partnership, and we are part of a larger national network. If there's one thing I want to make sure I focus on today, it's this slide. When your eyes glaze over or your ears or your brain wanders about quality improvement, I want you to think about the fact that we're all here because it's about the kids, and that's something I think is so fantastic about pediatricians, that we get to spend time always thinking about our future. The second is that QI is founded upon science. So I think that's something to always go back to. Why are these principles important? Something that you can always think about in terms of your daily practice, that you're implementing science in your practice. Very simple objectives. Let's just review really quickly why quality improvement is important in clinical practice. Why do we care? Besides the fact that as pediatricians, we've pretty much dedicated ourselves to quality for children, there's some other things that we probably want to review. Second, how do we start? So some of you are very well-versed probably in quality improvement, and others may not be. So I try to focus this presentation to make sure that we identify both your needs. And then to continue to consider team-based strategies to support processes for change. So a word about UPIC. In designing this multi-state project, the Utah team wanted to make available to you as clinicians and clinical teams QI specialists. These QI experts are from the UPIC organization. UPIC is a collaborative effort formed to assist clinicians in implementing quality improvement at the practice level, and we have led over 40 quality improvement collaboratives, and we've supported more than half of the pediatricians in the state of Utah. We're very happy that we've had the chance to work with many of you, and we hope we have that chance to continue to do that. So what is happening in healthcare today? This will help provide some context for our conversation. Some of you have maybe seen some of these words. We've talked about capitation, we've talked about team-based care, measurement, cost effectiveness, value, the triple aim. Really, we just want to remind you that 15 plus years ago, the IOM, now entitled the National Academy of Health Sciences, placed a report, Crossing the Quality Chasm. And it basically identified that our healthcare system is not great, doesn't have great quality. And these were the 6 aims: safety, efficiency, effectiveness, being patient-centered, equitable, and timely were aims that the report challenged us as clinicians to shoot for and to aim for. And currently, we know that there's a lot of changes in the delivery and payment space. Reforms are happening, and I think that that underscores why we feel quality improvement is becoming rapidly the center of our focus. So in clinical care, just a reminder, what is quality? What is quality? The IOM states that the quality is the degree to which health services for individuals increase the likelihood of desired health outcomes and are consistent with our current professional knowledge. Sometimes that knowledge changes. Quality improvement, what is that? Systematic and continuous actions that lead to measurable improvement for services. One of the great things that I appreciate about quality improvement that I wasn't actually taught formally, but learned by trial and error, is that quality improvement is really focused on systems. It's not punitive. So when I first came out of residency, I was involved in what we called quality, but it was actually quality assurance, and it was punitive, and I had a rude awakening about the differences between quality improvement and quality assurance. So that's something I think is really important as you continue to practice in your current clinics and as you teach those around you. QI is focused on systems, not individuals. The ideas and changes typically originate from the ground level. So from you as clinicians, from your clinical staffs, typically we focus on small tests of change. We recommend frequent ongoing measurement to give us data to drive our decision making. It's continuous. I know you are all excited about that it's never ending. It's our new work. I'm glad I got some laughter from our group here. And it should help us. It shouldn't hinder us, but it should help us to close that gap between what we know we should be doing and what we're actually doing. So, given the limited time that we have today, our goal is not to have a workshop on quality improvement tools. Some of you employ those in your practices already, but I do want to highlight some tools. Population Health Improvement Partners and Institute for Healthcare Improvement, IHI, both have tools that are ready for your use in your clinical practice teams. And I just bring that to the foreground. You can use any tools that you find. Many organizations have tools. There's no bias on our end for what tools you may look for. So we first covered why we think quality improvement is important and currently under the clinical context of the healthcare environment. And now I think the most important thing is to talk about how do you get started. So in some of your teams, it's very natural. You may already be doing quality improvement work. Some of you may be wondering, how should I get started? So I just outlined it as simple as 1, 2, 3. So first, in general, you're going to select a project or a topic. And for us, as a group, 55 physicians and clinical teams, we're going to work on improving HPV vaccine rates through QI methodology. The second is you're going to assemble your team, and that's really great. You get a chance to pick your team. Quality improvement is a team sport, and I love that we have the chance to think about the people we work around, the people that we work with every day, and really focus in on the skills and talents that we have as a group of people. And finally, use a roadmap. We're here to help you with that, and I will talk about a specific roadmap that we recommend. So first of all, choosing a focus. In general, when you're thinking about a quality improvement effort after the HPV project, we hope you continue with these principles. You'll start by creating a project which helps to define and formalize your effort, and it will shape the scope of what you see as problems. And these are ways in which you can determine a focus. You can ask yourself, where's the quality gap in our practice? What are the goals of the care that we have for our practice? What kind of care are our patients actually receiving? And to help you understand your problems in quality care, you'll want to use tools. Process mapping is a great team exercise. That's something that our quality improvement coaches can guide you in. Observational walks. So using an opportunity from a management standpoint to see what's happening on the front line and to engage your frontline staff. And then data queries. I know all of you want your EMR to work for you. You want to stop working for your EMR. Okay, the second is, now that you've selected a topic area, and we know for our project it's going to be HPV, assemble your team. Select your team based on their knowledge of and involvement in the processes that you want to consider changing. And these are suggested roles that we would recommend that you just try to fill in your team. Someone to sponsor this, someone who's making decisions about the policies and practices within your clinic. That may be clinicians, it may be administrators, it's probably a partnership of both. A QI team lead of some kind, a clinician lead. So if there's multiple physicians participating in your practice, we recommend that you select someone, identify someone to be your go-to person for this. A QI expert or local experts can be part of your team. UPIC certainly wants to fill that role. We have Deanna Kepka here today. She's got incredible HPV experts who can be a part of your team, and then a QI project manager. So recognizing that the process of QI work also includes the desire to keep things organized, and so project management is important. Tuckman's stages of team development. So we don't oftentimes talk about our teams. We just assume we're going to work together and it's all going to be fine. But actually, there's a framework in which teams function. And oftentimes, as you're developing your team or as you're formalizing your team effort, you'll see that there's stages. So there's forming. Oftentimes, there's storming, where you may notice that there's differences in the perspectives that your team members have about a project or an effort. Norming, where you may come to consensus, and then performing, where you're really actually functioning as a unit, you're learning together as a unit. This is a tool that I bring to your attention. It is on the Population Health Improvement Partners. It's something you can print and just fill in if you feel the need to think about your team if you've got a large team. And if you only have a small team, you can also think about this too. You identify member characteristics, you think about the skill sets that your team members bring to you, and what you're hoping the team roles will be. And this is just something that you may find useful as a tool. Finally, so once you have a topic and a team, so we're all focusing on HPV, you're going to be selecting who your team members are. Consider the approach or the roadmap that you're going to follow. And which ones should you use? There are many out there, DMAIC, Lean, Six Sigma. We recommend the model for improvement, and the reason for that is because it's simple, and we also know that it works. So the model for improvement, and I'll tell you who developed this, tests and evaluates small changes before they are brought to scale. It allows for a systematic analysis to determine the effect of the interventions or intervention that you're going to pick to help you identify if you're improving. And this is why I love the model for improvement, because it asks the learner 3 questions. 1, what are we trying to accomplish? 2, how will we know that our changes are an improvement? And 3, what changes can we make that will actually result in an improvement? So for those of you who are familiar with QI and you've been doing a lot of QI in your practice, and you are veterans or seasoned clinicians, I would encourage you to continue to ask yourselves these questions as well. This is a visual representation. This is from the Associates for Improvement and developed by Langley and Nolan. And this is a visual representation, which not only shows the 3 questions that you ask yourself, but then how you use those questions. So once you decide about a change idea, you're going to go through a cycle called the PDSA cycle, the Plan, Do, Study, Act. And if you remember, I said QI is founded in science. We have modern improvement scientists who've led and blazed the trails for us. This Plan, Do, Study, Act comes from that history. So first, what are we trying to accomplish? You're going to understand the problem together. Learn as a team. You can ask yourselves, what is the current process from point A to point B? Maybe you know what the problem is, but you don't know what the root of the problem is. Or maybe your question is how much variation exists in the process that you're focusing on. So visualize how you deliver care. And we like to do that very simply through a process map. You can use some other tools also, but I'm going to show you process map. And process mapping should be very simple and hopefully intuitive. It can be formal, it can be informal, it can be technical and very detailed, or simple and sort of a bird's eye view. There's no one right way to do quality improvement, right? So here is a flow chart. If you're having a bad day and you're starting someplace and then there's an exit, what's your current mood and what are you going to do from that? How about this flow chart? I have to ask my audience here, how many of you like Nutella? Okay, thank you. Okay, so here's a simple process map for HPV delivery. If you'll notice, I didn't use a whole bunch of fancy diamonds, circles, and squares and rectangles because I know that for us, sometimes trying to remember what's a decision icon and what's the actual process icon, what we're just trying to say is map out how you deliver HPV care from when the patient comes to clinic and when they're discharged. So what are the current steps in the process of care for your kids ages 11 to 17, 11 to 18, 11 to 12, arriving for well child visits? And at UPIC, when we walk through these processes with practices, we oftentimes break them down into pre-visit planning, during the actual visit with the clinician and the interface with the clinical team, and then post-visit on discharge. One very important aspect of quality improvement is to ensure that you have an aim statement. An aim statement can also be known as a SMART goal. It is vital to help define the scope of your work. Once you develop your aim, once you understand your problem, and that's always a challenge because you might try to develop an aim and then realize that the actual problem you're working on doesn't relate to your aim. But I recommend making it public. Tape it to your office wall as a reminder. And really, the aim statement consists of asking or stating what your effort is, for whom are you targeting, and by when. And I think that's really important to remember. What, for whom, by when. And this is an example of an aim statement. 30% of children ages 11 will receive all adolescent vaccines at their well-child visit over the next 9 months. You can pick a different aim statement. That was just an example for you. Second, how do I know if my change led to an improvement? I know all of you love measures. I think that we're probably in healthcare measured out. But I just want to show you that in measurement, we typically ask ourselves, why are we measuring? Are we measuring for accountability, research? No, we're actually measuring for improvement. And there are different purposes for measurement. For improvement, the purpose is to understand our process. It's to spur change or to evaluate how we're giving care. It's flexible. We reserve the right to change based on what we're learning, how we're going to continue to conduct our quality improvement work. The scope is usually the practice level. It's very local. And then we use run charts or even control charts, depending on the number of data points we have, to help determine if our change is an improvement. So keep in mind in your practices as you're developing measurements for this project to limit the number of measures. Maybe all you need is one measure. Maybe you need a few measures to help you understand if your process is moving you in the right direction. Keep your data collection as simple as possible. So we have Sam Plum talking to us about QIDA, and that will be a tool that you can use so that your data collection can be simple. Measure frequently, use small sample sizes. And there are a few different kinds of measures. We're not covering that today, but if you have questions about that, our QI coaches are available to you. So here's one measure you could consider: a monthly tally of all your adolescents, organizing them by age, and finding out, did they get their HPV vaccine, yes or no? But Dr. Cosgrove is going to talk to you about some change ideas, and so because of that, you may want to develop some process measures reflecting the changes you're making. And here is a simple run chart that reflects a process measure. The change intervention was provider prompts. We thought that provider prompts in our practice might help us increase HPV vaccine rates. You can see on the x-axis time, on the y-axis proportion or percent. And over time, were we using provider prompts? And the answer is yes. We were at 0 in the first 2 months as we got our processes in place. And then we measured ourselves as a practice and then across a group of practices, whether or not we were using provider prompts. And our practice was actually outperforming other practices because we felt provider prompts were so important. I think other practices might not have necessarily used that as a priority. Finally, third question: what changes can we make that will result in an improvement? So the PDSA cycle is shorthand for testing a change by 1, developing a plan to test the change, carrying out that test, so you're going to do, observing and learning from the consequences, and determining what modifications should be made to the test. This worksheet is going to be made available to you, and we'll send out links, but it's just another tool that you could use to keep track of your PDSA cycles, which we recommend. It's small print, so I'm going to continue on, but if you are curious about that tool, you will get that in your follow-up email. So in summary of what we just talked about, how to establish the processes. So obviously, we've selected a project. We're aiming to improve HPV vaccine rates. How you do that is going to be up to you in your practice. You're going to assemble your team, and we recommend using the Model for Improvement as your roadmap. Take-home points for all of our wonderful states involved in this multi-state effort. Remember to understand your problem. The tools are there for your benefit. Create your team and celebrate this improvement together. Focus on a clear aim. So not all improvement requires change, all improvement requires change, but not all changes lead to improvement. You've probably heard that before. And select a meaningful measure. It should guide your improvement cycle. we all know this is actually what improvement looks like, though, right? So we think that improvement is probably this nice, tidy thing, and we, in reality, know that it's not. That you start from one place and you think you're going to end, but technically you're supposed to keep going, and the reality is there's a lot of turnoffs from a nonlinear circumstance, but that's great because that's why we love QI. We get to learn from it. So I like to say celebrate improving. Celebrate improving. That's different than celebrate trying to improve. That's different than celebrate improvement. What we're saying is embrace the pain by celebrating that hard work that you're doing together. So I'm going to say it again, celebrate improving. So thank you for your time. Remember, it's about the kids. These are my 2 kids. I'm so grateful that there's a vaccine that I can give to them, that we still, the science of vaccine is so fantastic that we still are developing vaccines, and now we have one that could save lives in a way that we didn't have before. I'm excited for Deanna to talk to you about that. Our QI coaches are here to help you. My email is listed. You can contact me if you need anything. And if you have any questions at this point, we'll give you a chance here. And then for those states that are listening to this as a recording, please send us your questions. We're more than happy to answer them. Thank you.
Our concluding speaker today will be Dr. William Cosgrove. He's the past president and the current immunization champion for the Utah chapter of the American Academy of Pediatrics.
All right. Good day. I'm Dr. Bill Cosgrove. I'm a pediatrician, and I'm the project director. I've been the chapter champion for immunizations for the Utah chapter for the last 30 years. And we went after this grant to try to improve our HPV rates. My talk today I'm going to be trying to talk about several items, kind of batting and clean up here, trying to fix all of the loose ends. So first of all, as far as conflict of interest, I have none. Nobody pays you for this work. I want to talk about our project. This project is eligible for MOC Part 4 credit, and I just wanted to remind you about what that means. Over the course of a 5-year recertification cycle, pediatricians need to accumulate 100 maintenance of certification points in that 5-year cycle. 40 points are Part 2. That's that you can pick that up either online or through conferences. And 40 points are Part 4, which requires you to do some quality improvement work in your offices. And then the last 20 points could be in either. This project is 25 of those 40 points in Part 4, and we are endeavoring to make it as easy and as painless as possible. The project requirements require that you attend our monthly teleconferences. There'll be 6 of those, or you can review them later. They'll be all archived on our website. And you need to record data. This is a quality improvement project, so you sort of have to kind of show that you are doing quality improvement in your office. And the AAP has made available to us their QIDA system. I'll explain that in a minute, to help log some data to summarize your work. And then in the next 6 months, your team and your office need to complete 5 continuous monthly cycles, so 5 in a row. So we're trying to make this as easy as possible for you, as painless as possible for you in your office. We know you already are doing 60 hours of work in your 40 hours, so we're trying to make this easy. So why should we improve? Well, you've heard particularly Deanna's talk about the stakes are high in HPV. And even the best of our practices, some of the best of our practices can get maybe to 70% immunization rates for our teens. Most are in the 50 to 70% range. So we're leaving a lot of adolescents unprotected, and we need to catch them. We need to figure out how to do a better job. And what we've done for the last 11 years has led us to be only a little better than half effective at this, so we just need to find ways to do new and better work. We're not suggesting, and we don't want you to be fearful about the fact that the quality improvement means that you have to abandon what you do best or abandon what you already knows work. What we're talking about here is no monumental changes, no dramatic disruptions in your practice. We're just looking for ways to make incremental improvements, incremental tweaks in the process so that we can get this job done a little bit better. So quality improvement is about data, and data can be daunting. So I'm going to kind of give you a metaphor to think about. If you were rowing a boat across a river, you could certainly aim the keel of that boat across to the target across the river, close your eyes and keep rowing and hope and wait until you hit the other shore. But you know that's not going to work. Other things are going to get in the way. There are currents in the lake. There is wind. One of your arms is likely stronger than the other. If you just close your eyes and row, you're probably going to row in circles. You're probably not going to get to your destination. So what you have to do if you're rowing that boat is you have to stop occasionally, figure out where you are in the lake, pick a new target, pick a new direction, tweak your aim a bit, and then row again for a little bit. And again, remember to stop occasionally to check your progress. So the new data is not about proving that you were right or wrong with your last choice. It just gives you feedback about where you are at the moment, and then you get to decide where to aim next. Now, the AAP's Quality Improvement Data Aggregator, that's a mouthful, and this is another computer program, and all of us have gone through a few EMR changes, agonize about when somebody brings up yet a new computer program, yet a new login, yet a new password to remember. So I promised you we're going to make this simple and easy. So I'm going to breeze through this. I'm going to show you 5 screens. That's all you have to pay attention to, 5 screens to get this job done. And this will be archived so you can go back and look at this. But again, it's pretty simple. First of all, this is the home page for the AAP's QIDA website. This is actually the homepage of our previous project that we did using it. And the first thing is you'll be given the actual URS to find this. Probably the hardest part that you're going to have to realize is that it's key data and it's QIDA. And the hardest part for me is not to remember not to put a Q after that U. If you in English, almost always, if you write down a Q, it has to have a U. There's about, I think there's maybe a couple words. Iraq doesn't have a U, and Q fever misses the U, but almost everything else has a U. This one doesn't, so you have to leave out the U. You click on that, then you go to this part of the page. You put in your AAP number, your ID number for AAP. You put in your login for AAP, and you're done, your password. And that takes you immediately to our project. And there's a lot of information on this page. You can just ignore it all. And you simply go to this page, and then you pick My Groups. My Groups are the group that you have in your office, in your practice. You will have a group. So you click on My Groups. Okay, that's page 2, a second screen that you have to work your way through. This will be populated to have the names of the people in your office, particularly the practitioners in your office, whether they be pediatricians or nurse practitioners or physician's assistants, the people who are joining us in this project. And on this page, again, there's a lot of other information that you can totally ignore. You just have to enter practice data, which takes you to a new screen. And again, most of this information you get to ignore, but at the bottom right, you can, at the end of the month, we're going to ask you to go back and pull 10 charts of kids you saw that month. And so you put in the number of charts. If you only had 6 kids, then you'd have to put in number 6. If you'd like to enter 40 kids worth of data, 40 charts, that's fine. You just put in how many charts you have as your denominator, and then how many patients completed the criteria. This page is just about initiation. The page that you will see will be about initiation and completion rates. And then you hit submit, okay? So I've taken you through 3 pages. that takes you back to your page, the My Groups page, and then if you swing over where I've got it circled there, you can run chart report, and that gives you just a simple run chart of your data. That's all. That's all you have to do. So you have to click through 5 pages, you have to put in your data, a numerator and a denominator. We're not going to ask you to be statisticians. We're not going to ask you to be fancy. The QIDA tool from the AAP will let you be fancy if you'd like, but for this project, you can be just plain simple. I mostly mention that so you don't get scared about or worried about it. So the goals of our project. We're hoping that participants will learn something about quality improvement. We're not planning to make you experts. Something about their own HPV messaging. I'm going to talk about messaging in a minute. Something about themselves. We all bring our own lives and personality to our work, and that can help us or hurt us. And then something about teamwork. Teamwork is important here. So teamwork. Immunizing is a team sport. You could be the world's best pediatrician, and if your MA, as they're putting the patient in the room, tells the mom or acts like immunizations aren't important, you can't succeed. You have to have a whole team. You have to have whoever handles the phone call for to make the appointment, whoever is the receptionist at the front desk, the MA that puts the patient in the room and weighs them. All of those people are going to be hit with questions. All of those people are perceived by your patients' families as part of the team of experts to advise them about what's right or wrong for their child. So again, if your receptionist says, oh, that's not important, they've just made a hill that you may not be able to climb over. So you have to get your team involved. And so every member of the team either adds to or subtracts from your effectiveness. And really you're going to be working with 2 teams. A small team to just kind of pay attention to the data, take the data, and then think about where you want to direct your efforts next time. And so just change course. That may probably be a pediatrician and maybe your MA or the person in your office, maybe an administrator, just somebody who you can talk about how to redirect your efforts. The second team is the whole practice. And again, that's everybody. That's the receptionist, your billing people, everybody who is the face of your business, everybody who answers the phone is going to get asked questions about vaccines in general and HPV in specific. And whoever is being the face and the voice of your business needs to have the same words. So this is quality improvement. We're assuming your quality isn't perfect yet. Sorry, no offense. But our perfection is not our goal. Essentially, we're attempting to learn from our mistakes. So the overall goal here is get busy making mistakes. Try out different things. Even if you think you got it right, change it a little bit and see what difference it makes. See if you're really right or not. And the main thing is just take enough data so you know where you've been, so you don't have to circle back and do that again. And as you look back at your progress, you'll learn something, and that something will help you improve. So what are we trying to improve? We're trying to improve the immunization rates of adolescents against HPV. So as far as the global picture of immunizations, you already know how to do this. You already know about how to handle the usual tasks of ordering the right vaccines, handling VFC versus commercial vaccine, how to deal with all of the cold chain hassles, how to deal with storage and staff training, and how to get your MA to hit the right part on the child's thigh. You know about billing. You already do all of that for all of the other vaccines. The difference, that's our usual practice, and it works very well for most vaccines. But for HPV, we're missing too many kids. Something is wrong. And that something probably has to do with the messaging surrounding HPV. So we're going to talk more about messaging. So your words matter, but your words are only part of the package. So much of our communication, so much of our building trust with families depends on more than our words, body language. So be calm. Sit down, relax, act like you've got all the time in the world. Some of this is just acting skills. What I find is it's easier to keep the trust with families if I have my stool a little bit lower than eye level of mom on the bench, so that I don't have to deal with being intimidating to that person, and I allow them to have a little bit more power. Just setting it up, and then take a deep breath before you answer. If you're tense, that's going to come across. If you're calm, that's going to come across. If you're confident, that's a lot more about body language than it is the words you choose. Now, if you list the Tdap and the Menactra as, well, of course we're going to do those today, and and we have to kind of talk about HPV too. If you separate it, if you act hesitant, or if you don't seem to come up with it with the same a lot of consonants, well, your actions, the patients, the family is going to follow your emotional message much quicker, much more carefully than your words. So if you don't pull it off as a good, calm, confident acting job, your words don't matter. So in terms of delivering the message, you're the expert, but you're also a salesman. Your attitude, your belief in the immunizations, your body language are louder than the words you choose. And what you're selling is life-saving prevention or protection. So you have to win them over with your conviction, the strength of your belief, the rightness of vaccines. And again, it's not the words you choose. The words are important, but it's kind of the delivery that's important. So how do we improve your message? Where do you start? Well, first of all, you start by writing down the words. Keep it simple. Keep it direct. I would put all of the vaccines, the Tdap, the Menactra, and the HPV together. And the several studies have shown if you simply put HPV in the middle of the sandwich, Tdap, HPV, and Menactra, it normalizes it. It says this vaccine is just as good as the other two. It doesn't separate it out. You don't have time to get any hesitation in your voice. It just gets the message across quicker. And then what's clear is you have to have a strong recommendation. You can't be wishy-washy about this. You can't, this isn't a suggestion. This is, this is about saving lives. So, if a child was drowning in the pool, you wouldn't say, well, we could do this today. You just get it done. We're talking about saving lives. Get it done. So, the CDC has been taking a lot of data. We've been failing at this job for 11 years straight. So, they've done a lot of studies, a lot of little pilot studies. What's clear in all of the research is that your message needs to be simple, strong, consistent, and make it a strong, consistent recommendation. And again, it's a team sport. If you are building this message and your MA is cutting the legs out from under you, you just have to sit down and talk to that person and make sure they're on the same message. Now, strong recommendation. Say it like you mean it, like lives are at stake here. Because guess what? Lives are at stake here. So let me talk about lives that are at stake here for a second. In terms of trying to communicate the need for this to yourself and to your families and even to your staff, the statistics can get overwhelming. But I'm going to give you the statistics in a very simple format. 10 kids. If you immunize 5 girls, if your MA immunizes 5 girls, she saved one of them from the 6-month torment and fear of an abnormal pap smear. So after 5 vaccines, you may want to celebrate with your MA that we don't know which of the 5 she saved, but she saved one of those 5 from an abnormal pap smear. If you immunize 10 boys and girls, you saved one of them from the agony and the torment and the body image problems of genital warts. If your MA has immunized about 125 girls, she saved one of them from cervical cancer. If she's immunized about 120 boys, she saved one of them from oropharyngeal cancer. If your MA has immunized 500 kids, she saved a life. You may want to mention that. We're talking about lives here. And your MA probably has already saved lives with this. So, homework this month. And again, we're going to bite this off in little chunks. Each month, we're going to give you a little different challenge. We're going to give you a little bit more information. We're going to teach you a little bit more, but we want to start simple. So first of all, you need to know where you are. So pull charts of the last 10 young adolescents you have, 11 or 12-year-olds. This project is just about 11 and 12-year-olds. Still, please immunize your 18-year-olds, but this project is just about 11 and 12. Pull 10 charts. Count how many have gotten the initiation dose, the first dose, write it down. How many have gotten their second dose, completion, write it down. So what you've got is you've got two numerators and two denominators. And, two numerators and one denominator. And then try to figure out what it is you do. Ask your receptionist what she says when somebody has a question. Ask your MA what she says when somebody has a question. Find out what they do in the process and just write it down. We're not trying to judge it as good, bad, or indifferent. We just want to know where in the lake we are today. Then have a team meeting and share with your whole team why you're doing this. We're saving lives here, okay? And then we're going to encourage you to have part of your team on the monthly calls, particularly the part of the team that's going to be dealing with the quality improvement part. But for your whole team, the whole office, we'd encourage you to take the segment that's the HPV Survivor. That's the emotional hook, the reason why we're doing this, the reason to remember it on that 14th patient in the afternoon, the reason to care, the reason why we do this work. Have your whole team watch the small segments that are the HPV Survivor talks, because again, they have to care to do this work. And that'll help to give relevance, the emotional relevance, and give meaning to our work. And then on the monthly teleconference, please try to participate during the live teleconference, but they're all going to be archived, so if you miss it, you can log in to our website, which is aaputah.org. And each month we will hit a new QI topic to help you understand the math and the process. We'll give you a new messaging suggestion. We will hear a different survivor story. And again, each month we'll celebrate your successes, and we're going to celebrate your enlightening failures. Knowing what didn't work exactly for you is as important in improving our process as knowing what worked. And then let us help you succeed. We set this up. We have access to good experts for you. We have quality improvement experts. We have Deanna and her, I think it's now 9 statewide team of HPV zealots. We can get you information and handouts. And so call us, and I just put our chapter number there, but we'll act as your triage. We'll help you get in touch with the people that you need. And I'd like to thank you for joining our process, joining this project. And I would like to open it for any questions that you have for any of our speakers. If you have a question, just type it into the chat box. And otherwise, we're going to call an end to today. And we have one more thing, and that is we will send you the information about the date and time of our next teleconference, but it's going to be the first Tuesday of March 6th at 8 o'clock in Utah and Wyoming, and 6 o'clock for our friends in Alaska.
Johnson wants to know your experience with this.
What's the question?
What is your experience with this?
Oh, okay. One of our the people online asked, "What is my personal experience with this?" Okay, I just recently retired after 34 years in private general practice, and because of that, and because I was our chapter champion, I was involved with essentially every statewide and countywide effort on immunizations here in Utah. My own, I celebrated when this vaccine first came out 11 years ago, and during that time I've tried everything. One of the definitions of an expert is somebody who's been around long enough to make every mistake there is possible so that they will throw out the bad stuff and are left with what works. And some of that I'll share with you, but most of that, each of us is different, each of us says different things, each of us different. So really we have to develop our own skill set. We can borrow somebody else's words, but we really have to kind of narrow it down to hone our own skills. So like a sports analogy, you can watch somebody else bat a baseball, but you're not going to be good at it unless you get out there and hit it. And my own experience has been in the trenches for 34 years until I crawled out of the trench last summer. Any other questions? Seeing none, I thank you for your attention. This will all be archived for those who, for your colleagues who missed it. We still have more slots available, so if you have offices that want to make an easy 25 points on MOC Part 4, we would encourage them to contact us, and we will get them involved in this project. Thank you much.